A pelvic congestion syndrome is the old name now called pelvic venous disorder. It's a group of cohort patients who have a pelvic migraine. Chronic pelvic pain is like a pelvic migraine that affect women in childbearing pain, characterized by being chronic non-cyclic pain of at least 6 months duration. According to Milka Griner, she classifies pelvic congestion into 3 categories. This is really important in categorizing these patients. Type 1 is valvular pathology or reflux pathology. Type 2 is obstructive pathology like nutcracker or May Turner. Type 3 is local gynecological cause. Most common type is type 3. That's why we should not touch patients who have a chronic pelvic pain who does not seek gynecological consultation first. Traditional therapy now should be the cornerstone, especially in the first 6-month duration. I will show why same venous pathology causes different symptoms in cohort patients and why same symptoms in cohort group were of different venous pathology. According to Mark Meisner, there are 4 venous systems, 4 reservoir, 4 zones, and a tool that really help in categorizing these patients. Zone 1 includes left renal vein, and it become evident especially in the case of nutcracker syndrome. Type 2 include gonadal and hypogastric veins. Zone 3, pelvic and the pelvic escape points. Type 4, zone 4, lower extremity varicose veins. It's different in female than in male. So in female, venous pathology are connected through from veins of the leg up to chest, through hypogastric perforators, escape points, and azygous system. For example, these 2 patients have same pathology, which is a Griner type 1 left ovarian vein reflux. But the patient on the left have pelvic pain, and the patient on the right have a lower limb pain. That's why, because the patient on the left have an uncompensated left ovarian vein reflux that transmit directly to the pelvic reservoir, and patient on the right have the pressure being transmitted through leg reservoir by pelvic escape points. And this is really crucial in management of these patients. The patient on the left, metallic coiling would be enough, and the patient on the right, it should be accompanied by fluid with metallic. Another example, patients who have a nutcracker or left renal vein non-thrombotic occlusion. If the patient transmits direct to the renal reservoir, patient would develop renal symptoms and the hilar varices and non-glomerular microscopic hematuria. If the patient transmitted directly through the pelvic reservoir, so it become a left ovarian vein reflux secondary to renal vein obstruction. This pressure could be transmitted either up to lower limb through pelvic leak points. The one below showed patients who have non-thrombotic iliac lesion. If the patient transmitted directly to the lower limb, it would be different in management if the patient transmitted through hypogastric vein into pelvic reservoir and maybe reach a lower limb again through pelvic leak points. Here's the SVP tool who done by Professor Mark Meisner, show how we categorize these patients in same cohort group and delineate the way of treatment. If the patient have lower limb varicoses or varicose vein secondary to pelvis, it should be accompanied by SEEP classification. Gluteal obturator, perineal, and inguinal with the clitoral point is the pelvic escape point. Perineal is the most common, then followed by inguinal. Inguinal and obturator seen in the anterior view, while perineal and gluteal seen in the posterior view. Gluteal and obturator see inside the true pelvis, while perineal and inguinal see outside true pelvis. Why is this important? Because if a patient come to the clinic who have a pelvic-derived lower limb varicoses and she have suffer from medial thigh varicoses, we should search for obturator vein varicoses. If the patient have a lateral thigh varicosity, we should search for inguinal vein varicosity. If the patient have gluteal or sciatic varicosity, we should look for branches of hypogastric, especially gluteal veins. Here is the latest ASV guidelines 2022 for patients with varicose veins of pelvic origin without pelvic symptoms. Pelvic vein embolization as initial treatment should not be performed. For patients with varicose veins of pelvic origin with pelvic symptoms requiring treatment, pelvic vein embolization should be considered to reduce symptoms. For patients with suspected suprainguinal venous obstruction, in addition to full leg duplex assessment, ultrasound of the abdominal and pelvic veins should be considered as a part of initial assessment. The initial assessment of this female should start by transvaginal duplex. It will sieve this patient into two categories. A patient who have a complete reflux in internal iliac should undergo CT venography. A patient who have a reflux in hypogastric vein without valsalva, transabdominal and transperineal duplex would be enough. For female patients with pelvic pain and clinical suspicious of pelvic venous disorder, exclusion of other causes of pain is recommended. This is really crucial in selection of patients, which patient is fit for intervention and which patient should not be touched. For female patients with suspected pelvic venous disorder, abdominal and transvaginal ultrasound should be considered to confirm the presence of venous pathology. For patients presenting with symptomatic varicose veins where they may be pelvic origin, specific duplex ultrasound assessment of pelvic escape points is recommended. And now most of sonographic back in Cairo know how to delineate these pelvic escape points and how to correlate with the symptomatology of these patients. For patients with varicose veins of pelvic origin without pelvic symptoms requiring treatment, local procedure for varicose veins and related pelvic escape points should be considered as initial therapeutic approach. Here are some patients who have atypical or extra-axial varicose veins. Treatment of this patient should be directly toward the cause, not just the varicose vein. If this patient have a pelvic symptomatology, treatment of lower limb with pelvis is really mandatory. If this patient have no pelvic symptoms, treatment of lower limb would be enough. Here are some patients who have an anterior thigh varicosity. Most of accessory saphenous vein is really connected through perineum and through inguinal vein, which goes inside the round ligament. Here's some pictures of left gonadal vein in picture A. And picture B show how the castor is seen inside the left gonadal vein and the hypogastric and iliac vein being visualized through the same side, which exclude patients who have May Turner. And also siphoning effect of the hypogastric vein crossing to the right gonadal may help in understanding this picture that patient have no May Turner and have a normal right gonadal vein and despite being refluxing. Picture C show left gonadal vein embolization by glue. There is 3 types of glue, whether histoacryl, amicryl, or gluburon. Picture D, the glue after embolization. Here's some picture of right ovarian vein reflux before and after. We might use a coil in 3-way, whether uncoiling the coil or anchoring or scaffolding. And we might also leave the coil being uncoiled if the patient have one single huge gonadal vein. Here's some picture of right gonadal vein before and after. And here how we visualize the pelvic escape points for optimal treatment of these patients. As we said, inguinal vein is responsible for lateral thigh varicosity, obturator vein for medial thigh varicosity, and gluteal vein for sciatic varicosity. Here's some pictures. Understanding the type of saphenofemoral junction in these patients is really mandatory, and to differentiate between terminal and pre-terminal valve is really mandatory in treating symptomatic lower limb varicosity. For example, the picture in the left, metallic coiling here would not be enough because there are a lot of gonadal vein tributaries, so mixing of metallic and fluid embolic would treat this patient in optimal way. Here's some picture where we visualize obturator vein. If this vein is refluxing, so treatment of embolizing this vein is really important in preventing recurrent lower limb varicosities and for reduction of visual analog scale in treatment of this pelvic migraine. Here is a double ring sign in patient who have a circumaortic renal vein. We'll discuss it later. Understanding the type of subfemoral junction and to differentiate between terminal and pre-terminal valve in treatment of lower limb varicosities is really helpful in understanding if this lower limb varicosities is being derived from the pelvis or lower limb. In patients who have May Turner, this picture would be different. Visualizing the hypogastric and gonadal vein will be seen through the right side, not through the left. As a vascular surgeon, we also do renal vein transpositioning in case of nutcracker syndrome, where patients have a decline in aortomesenteric angle. Here's some perineal and vaginal varicosities. Thank you.